All right, thank you for having me. It's a privilege to be here. And I don't think did I see one hand, Intermountain Health? No Intermountain Health people today? That's okay. I'm excited to talk a little bit today about clinical excellence within Intermountain Health, but I do want to start with financial disclosure. My presentation today has no ineligible company content, promotes no ineligible company, and is not supported financially by any ineligible company. I receive no financial remuneration from any ineligible company related to this presentation. So we're going to talk about today clinical excellence within Intermountain, but more specifically clinical risk and safety, the team that I'm on. I do want to give a little overview of clinical excellence within Intermountain Health. You can see here it is system-led but locally deployed, and you'll see the next two words here, caring and learning. That's going to be sort of the mantra that we live by, and I'm going to refer a lot back to those two words. Simple words, yet they have a great impact on the work we do. So you can see all these different sub-departments within clinical excellence. My team does the clinical risk and safety work, so we'll focus mainly on that today. We won't have time to get into the others, but we do work closely together and we coordinate together so that we can provide the best and most safe experience for all of our patients. So first I want to talk about the why we do what we do in clinical excellence. And first, we want to foster a culture of psychological safety. Top to bottom, every caregiver within Intermountain Health, we want to ensure that they feel psychologically safe to speak up, to report all events, no matter the impact on the patient. Obviously, we cannot fix what we don't know is broken. So that's first and foremost why we do what we do and build trust within teams, both locally and system-wide. Second is to simplify. So this is looking at process management. This is looking at processes that we have both locally and system-wide and simplifying those processes, being a more efficient, as you can see at the bottom, a more efficient organization. Before we jump down to efficiency, I did want to touch on system learning. So obviously every patient safety event that we have occurs at a local site, but one of the reasons we do what we do is for system learning and sharing lessons learned across the system so that we can mitigate risk in any way we can. And then this in turn causes greater efficiency, and this is ultimately the why behind we do what we do. So I do want to set the tone here with some background on harm levels. So when we're talking patient safety events, adverse outcomes, we use the same language used by state health departments, by CMS, by Joint Commission for the harm coding system. And we use A to I, A being no event, no near miss, all the way up to I, which results in the patient death. So I will be referring to low harm and high harm here, low harm being A to E, high harm being F to I. So F being temporary harm requiring a higher level of care. So we're going to talk about how events are managed. Maybe. Thank you. So working from left to right here, we're going to talk about those different types of events and how those are managed. High harm events, there are 4 categories of events, not counting the litigation, which we'll touch after. There are high harm events and low harm events, both grievances and non-grievances. Grievances are those that are being, that come directly from the patient and or patient representative about the care that they received. So they're managed a bit differently. Starting from the left here, high harm events that are non-grievances, these are triaged by the clinical risk and safety team. So our team, we take these, we triage these, and we manage those and facilitate any work needed. If it's a high harm event that's a grievance, they'll be triaged by the clinical relations team. These are the patient advocates, and then we work collaboratively with them, and we'll co-manage those events. If it's a low harm event that's not a grievance, these we just leave to the local managers to coordinate any follow-up needed, and these are triaged by our team, our triage team, but they're managed locally. And then low harm events that are grievances, those are managed specifically by the clinical relations team, those patient advocates. And then obviously we have this last bucket here, litigation events. So similar to our last presentation, we have these events that come directly to the legal risk team. We manage these much in the same way we manage other events. The only difference is if there's not an event entered into our system, we'll enter a new event and start from the beginning. But we do work collaboratively with the legal risk team, so it's separate from the clinical work that we do. Sorry, my clicker's not working. Next slide, please. So now we'll go into the life cycle of a safety event from start to finish here. So we'd like to work from left to right here again. We'll go over each one and then we'll talk about each. So sorry, next slide, please. My clicker's not working here. So as I said before, we cannot expect to fix what we do not know is broken. So obviously the first step, next slide please, is the event being reported. So we utilize an event reporting system where, as I said, we have a team of triagers that ensure that every event, no matter the level, is being triaged and then it goes to the correct team to manage. In clinical risk and safety, we do triage as well events that come in as they come in immediately for what we'll be speaking on next for those events that are sentinel and reportable. So, and then non-reportable high harm events, they're sent for care review, and then all grievances, regardless of harm level, are sent for care review as well. So once these events come in, they're triaged, and then the first thing we look at, sorry, next slide, please. First thing we look at is reportability. So obviously there are different organizations that have reportability requirements for sentinel events, right? So we have the state that has its own criteria that can differ by state. We have the Joint Commission, we have CMS. If it meets reportability for any of the criteria, then we're gonna look, it's gonna trigger this first event that we call the Rapid Event Investigation, or REI. So what this does, it's a meeting that serves multiple purposes, but most importantly, it offers just as it says, a rapid investigation, which is done within 72 hours of event notification. So this is for all reportable and sentinel events, regardless of harm level, because if it meets the criteria for reportability, it could be on any level of patient harm. So we focus back on these two words here, caring and learning. That's our approach, is these two words, and it's very simple. First off, we want this meeting to serve as we want the audience and the discussion to center around that caring approach of not only the patient and patient family or any patient representative, is the caregivers involved. Obviously, we know as any caregiver from any level, patient safety events can have a negative impact, right? So we have multiple resources that we utilize. We have what's called EAP, the Employee Assistance Program, that offers different types of therapies and different things. We offer peer support, which is specific to just a peer in a similar field to be able to talk through things. We do what's called a safety pause, which we'll talk a little bit about later. But what we do is we have a quick 30-minute meeting within 72 hours. We focus on that caring, making sure that we're providing support to all caregivers involved as well as the patient and patient loved ones. And then we focus on the learning. So we really try and focus on what learning opportunities we have. Did we have any deviations from generally accepted performance standards, is the language that we use. Safety pause and debrief can either be done separately before the REI or it can be done in conjunction with. And like I said, I'll talk a bit about that later. We go through a process where we send it to the safety event notification team. This consists of local and system leaders in the areas where the event occurred or any area that is involved. And we get feedback on the reportability of the event, just to ensure that we that the event is in fact a reportable event. Then we move forward with scheduling the meeting. We ask leaders to prioritize this meeting because they do come up quick, right, within 72 hours of event notification. And then we hold the meeting, and we use that caring and learning approach. Regardless of the meeting that we use, the outcome or the goals are going to be the same, and we'll talk about those. If an event is not reportable, sorry, next slide, please. If the event is not reportable, but we still have, now we're looking at those high harm events, right, where there is some learning, we're going to be taking those to a separate meeting that we call the harm event assessment and learning. So similar to the REI, also similar format with those local and system leaders involved. And we're going to be taking the caring and learning approach. We're going to check in on the caregivers. The difference here is, besides them not being reportable events, because we can have events that highly impacted the patients and or loved ones, is that we're going to be potentially action planning in real time. So we're going to be, and we have more time to prepare. So what we will be doing with these events is we're going to be getting those care reviews from experts in the service line, right, or the specialty, physicians that are working over that specialty. We have an objective review done, so it gives time for more, for gathering more information on those potential deviations from care, as well as any learning opportunities that we have. We open up the discussion and we go through, and we also, the difference between these two teams is that in the HEAL, we classify the preventable harm. So every event will be classified. It's just a matter of if we're doing it in that meeting or doing it offline after. So REI, the rapid event investigation, we will classify offline after. So these are usually done within a month after the event. Like I said, we have more time to prepare and gather information. And what we do with the REI and the HEAL meetings is we are going to, if there is further learning or cause analysis needed, then we'll get executive sponsors. We'll ask for an executive sponsor from the local level as well as the system level. They will sponsor the event and work in conjunction with our team to establish further meetings needed for cause analysis and or action planning. And then we track those events in our system, and we do follow-up work with them as well. And there's great impact with that. Next slide, please. So as I said, either way this goes with a serious safety event, we're going to go to the rapid event investigation or the HEAL, the harm event assessment and learning. Regardless, we're going to look at further analysis. Do we need further analysis? And we can pull the appropriate parties together and do further analyses at whatever level we need, facilitated by our team in clinical risk and safety, led by the sponsors, and we obviously work to identify and then prioritize each cause and or opportunity. Next slide, please. And then from there, we work with those opportunities that we've identified, and we work on corrective action planning. So obviously, this is required for certain events, reportable events, but we're going to look at every opportunity and we're going to action plan around those. We're going to be using a matrix to determine the strength of that action plan, and then we'll be doing those check-ins. Usually, we look at doing 45-day, 90-day, 180-day, and then a one-year check-in for sustainability. And this is obviously critical for regulatory readiness as well. Next slide, please. And then arguably the most important part, as was stated before, is sharing that learning. So we have the collaboration with the system and local leaders so that we do have that system learning. And then we send out regular communication for these events with lessons learned so that we can spread the lessons learned throughout the system. Next slide, please. So we did already talk about the REI. We'll go ahead and skip this one. Next slide. And we'll talk about the goal for key outcomes. So we talked a bit about this, but specific to the REI, we want to make sure there aren't any immediate mitigation needs. We want to make sure that the care team is safe to continue caring for patients. So this is obviously looking at processes, but this is looking at that care, taking that caring approach with all caregivers, right? Making sure they feel supported, making sure they feel safe? Do they need, we have programs with HR if they need some time off, right? That doesn't eat into their PTO, where they can have that separately if they need it, right? If they need some time away. And this is at every level. And then obviously what we've talked about, support, and then identifying learning opportunities, and then coordinating next steps from there. Next slide, please. So the safety pause, as I mentioned, this can be done in conjunction with the REI, or it can be done for any event. Oh, sorry, can you go back one? Thank you. So the safety pause, we asked, so this is led by local leaders. This is basically a huddle that we can help coordinate with the Employee Assistance Program, peer support resources, any other resources needed to pull a team together and be transparent about an event. This should ideally happen very quickly after the event occurs, because that's when a lot of times the effect is the greatest on caregivers. We pull the team together. This can be for any level of event. It can even be for an emotional encounter with an upset family member. And we pull the team together, we offer resources, we make sure that they know that we're supporting them in any way we can. And this should be led by the local leader, local manager for that area. Sorry, still not, point over there. Sorry about that. So the big asks from local managers to help us in the process is obviously empower to partner with those local leaders on events, and then obviously documentation that will help us to track and trend those events when we're looking at the data. Next slide, please. We do utilize model safety language. We have the opportunity with Patient Safety Awareness Week that occurred back in March. We had the opportunity to do some rounding, and it's a lot of fun to go to different facilities and push for different ways that we communicate this safety language. And these are some of those phrases. Next slide, please. And these are some of the places that we were able to go and talk about that safety language and talk about patient safety. And it's such a great work. Next slide, please. So separate from the patient safety process, well, I shouldn't say completely separate from, but a separate process within the patient safety event system is the Good Catch process. So this is a great program that we have for events that specifically we identify were caught before they reached a patient. But there's potential for great patient harm, right? So it's an opportunity. We ask all caregivers, please enter any patient safety event in Good Catches. We love to see the Good Catches. And this is an opportunity for local leaders to receive notification of this and be able to recognize their caregivers, celebrate the caregivers for those wins. It's escalated for further caring and learning as needed, more of a proactive work, as well as senior leadership. They receive a weekly report and they do different celebrations. Next slide, please. So this is my favorite slide. This is the data going back 3 years from January. So starting in January 2021, this is showing the great effect that clinical risk and safety work has. So this is a 3-year period. You can see on the orange line here, orange pinkish line here, a gradual increase in the number of events reported. So this is that push for reporting everything at every level, right? And we've seen a gradual increase in those numbers of events reported. The blue line here shows a gradual decrease in the number of those serious safety events or preventable significant harm rate. So it's showing that what we're doing is working, right? That proactive approach to mitigate the risk and looking at patient safety at every level, those numbers of serious safety events are decreasing significantly, while at the same time, the actual numbers of overall events are being reported. So the actual events that reach patients that are considered serious safety events are much lesser. So it's opposite trajectory there, which is exactly what we want to see. And we want to see that continue on. Next slide, please. So to end here, one of our favorite quotes from the great football coach Vince Lombardi: "We will chase perfection and we will chase it relentlessly, knowing all the while we can never attain it, but along the way we shall catch excellence." So that's all I have, but I'd like to take any questions if you have any. All right, thank you so much for your time.